I think this might be the last in the despair. On my wedding day, one of the happiest days of my life, I was in so much pain and so tired I could barely stand. So I find myself in a situation where I'm forced into a life that is just existing. Dreams of having a great career and a large family are gone. Please help this cause. It may be too late for me to get all of my dreams back. It may be early enough to help the others that will follow. We then moved on to talk about the care of people who are experiencing pain. And we had the following findings. Remember in this IOM report, we broke things down into the findings, and then based on the findings, we had a series of recommendations. So the findings here were that we needed to tailor the care of pain to each individual person's experience. We recognized the highly individual and subjective nature of pain. At the same time, we also recognize that there are significant gaps. There's barriers to delivering appropriate pain care. There are significant gaps in the knowledge and competencies for providers. I'm going to get back to those gaps in knowledge and the education. We recognize that most of primary care providers are pretty uncomfortable and unprepared with taking care of the person in pain. There is inadequacies in subspecialty training, and we had institutional and system level barriers. These are some of the specifics in those barriers at the systems level, the clinician level, and the patient level. We've got the system levels, which you can imagine, the biggest one probably be reimbursement related and getting people the appropriate payments, the appropriate coverage to get the care they need. The clinical level barriers on a lack of appropriate evidence-based guidelines, adequate education, and education will come up over and over and over again. Appropriate policies, the insurance coverage I've already alluded to also in the system level. And at the patient level, our patients are by and large unaware. They're not well educated about their bodies. They're not well educated about management of pain. And also the issue with opioids, as I mentioned. Moving into the recommendations here, we thought that all care should really start with self-management. I don't know if I'm going to get into the details of this, but I'll give you the soundbite right now. When you're looking at 100 million Americans, and there's about 4,000 to 5,000 or so pain specialists out there. If you do the math, and I'll go ahead and do the math for you, that works out to about 30,000 to 40,000 patients per pain specialist. That just ain't going to happen, folks. That's not going to occur. There's too many patients. And guess what? If you just divide that by the number of primary care providers, the numbers don't match either. That means that care has to start in the home. My father used to play a lot of sports. A semi-pro athlete, a football player, weightlifter, got beat up a lot, and just suffers from a lot of chronic arthritic pain. And you know what? I can't get him to see a doctor about it. He won't even see me. He won't even listen to me. He just kind of sucks it up, grins and bear it. And I will bet you that that is really the vast majority of the patients out there. And what we need to do is empower them, to give them more information so that they can better learn how to care for their own painful conditions, particularly with the aging population that we're experiencing. These population strategies should include barriers to pain care. And then, once again, we need to provide educational opportunities for pain assessment in primary care. We recognized, I'm a pain specialist, but first and foremost, I recognize that after the home, it's got to be in the primary care environment. They're the gatekeepers. We need to better educate them on how to address this. We need to work more closely with the primary care and the pain specialty organizations to help improve the communication, to improve education, and improve when they should transfer or refer a patient with pain. And we've been doing this as a big issue. This is a big one we've taken on, the American Academy of Pain Medicine, to work with the primary care groups. We need to revise the reimbursement policies to foster coordinated and evidence-based pain care. People in our group hear all the time that, I lose money at Stanford left and right, providing the coordinated care that we provide. I pay for it, with the procedural revenue that we bring in. So I rob from Peter to pay Paul. And we often are denied coverage, as you guys know, on many of the things that have been shown to work. And that's unfortunate. We need to revise these policies, and we need to change the reimbursement strategies so that we're not overly incentivizing or having these perverse reimbursement strategies for things that may or may not work. We also need to get healthcare providers to provide consistent and complete pain assessments. and teach them how to do this. Moving on now in this narrative to stigma and marginalization. And by the way, I need to give credit for pulling these quotes out to Melanie Thurmstrom. She was on the committee. Melanie wrote a New York Times best-selling book called The Pain Chronicles. An incredible author. She now lives in Palo Alto down the road from me. And she pulled out these quotes and helped categorize them. If you ever want to read a great book on pain, by the way, The Pain Chronicles is fabulous. I'm 38 years old, have an MSSW, and a well-documented illness to explain my pain. But when my pain flares up and I go to the ER, I'll put on the hospital gown and lose my social status and my identity. I'll become a blank slate for the doctors to project their own biases and prejudice onto. That is the worst part of being a pain patient. It strips you of your dignity and self-worth. It allows people to think it's okay to project their biases and prejudices onto you. Even though I've never smoked a cigarette or even been drunk, I'm constantly accused of drug seeking and or malingering. Number 2, I don't know of any other condition in which that is the case. Why is it okay with pain patients? Is it because our pain is invisible and unquantifiable? We're not all drug addicts. We're not all criminals. We're suffering needlessly. I haven't done anything wrong. I've suffered so much at the hands of doctors who are supposed to be helping me. Where is their compassion? How much can one person endure and still be expected to handle it with grace and dignity? And finally, number 3, it has been hell. First, you have to find someone who believes you. Doctors don't recognize pain they cannot see or diagnose as a specific issue. The stigma is one of the biggest barriers. I've been treated like a lowlife by medical people when I disclose that I have chronic pain and use opioids for it.